The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBrS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
we're coming to you live from the poster sessions here at ASBrS 2026.
I'm Jennifer Goss from Brown University, Providence, Rhode Island. This is an international prospective randomized trial comparing supine MRI guidance called the breast cancer locator to standard wire localization.
So I'm Hannah Mathers. I'm down at Inova in Fairfax, Virginia. My poster is From Predict to Practice, a single institution retrospective review of outcomes in women with ductal carcinoma in situ.
My name's Taylor Fisher. I'm from Creighton University, Phoenix, with their general surgery program. My poster is talking about PEC blocks, specifically PEC 1 and PEC 2. We were looking at cost reduction.
My name's Kate Lloyd. I'm one of the breast surgery fellows at Mass General Brigham. We have a really robust database of nipple-sparing mastectomy that we reported patients undergoing nipple-sparing mastectomy between 2007 and 20.
Hi, my name is Paige Blinn. I'm a current breast surgery fellow at the University of Texas Southwestern. Our project is titled Patient Satisfaction with Robotic Nipple-Sparing Mastectomy, a prospective study of patient reporting outcomes using the breast Q. With the emergence of the robotic nipple-sparing mastectomy.
This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
we're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
We're coming to you live from the poster sessions here at ASBrS 2026. This is one of the most dynamic and fast-paced parts of the entire meeting.
This is where ideas meet real-world practice, where surgeons from across the country and around the world share breast cancer questions they've been chasing, the problems they've been trying to solve, and the lessons they've learned along the way.
In this episode, we're stepping onto the poster session floor for quick, focused conversations with presenters about their work. We'll learn about their research, the problem they set out to solve, what they discovered, and why it matters for the future of breast surgery. These are real conversations with real surgeons about the work that's shaping how we care for patients every day. Let's head out to the floor. Welcome to the Next Breast Thing podcast. Interesting study. We don't see a lot of posters with randomized trials. So can you tell us a little bit about it?
I'm Jennifer Goss from Brown University, Providence, Rhode Island. And so this is an international prospective randomized trial comparing supine MRI guidance called the breast cancer locator to standard wire localization in breast conserving surgery for non-palpable breast cancer. So we accrued over 400 patients and randomized them to either our breast cancer locator, which is a 3D printer shell to the woman's exact breast generated from a supine MRI. And onto that shell, her cancer is transposed, and around that perimeter of the cancer, 4 wires are placed through silos that are specific to her. So in the operating room, under anesthesia, the patient has a painless wire localization around the perimeter of the cancer. And so the value of that technique is we were able to reduce positive margins in the whole cohort from 21% to 14%, a 30% reduction in positive margin. And then in our special subgroups where margins are always more difficult to achieve, clear margins, we had a 60% reduction in invasive lobular carcinoma and in DCIS. We had a reduced rate of re-excisions, and our specimen volumes were comparable. So we were really excited to reduce the need for second surgeries in cancer patients.
And I think that's a really important thing, and congratulations on this trial. My question is, for those of us who not anti-MRI, but think that there's specific patients, it's certainly not for all patients. How do you get around that with this?
So to answer your question exactly, it's the invasive lobular carcinoma and the high-grade DCIS that's going to enhance on the MRI and more likely have more extensive MRI findings than your mammographic finding. So I think for that patient subset, the BCL is a great technique for localizing the tumor and avoiding a second re-excision. So you might not use it for every patient, although we did have a lower positive margin rate for every group. But the biggest value is in the non-ductal cancers, in multifocal cancer, and in DCIS, where I think those are indications where you'd be thinking about a breast MRI anyway.
So not a tool for every cancer patient, but specific subsets.
We were successful in every cancer, but we gained the greatest value in those subsets, invasive lobular, high-grade DCIS.
So did you look at, with the MRIs, how many additional second look ultrasounds and additional biopsies that were needed if we're talking about value?
I can't give you that data today. We know from all patients who get breast MRI that there's a 30% detection of additional findings. Half of those are relevant to this surgical procedure, so there is an additional cost. There's the EISEN meta-analysis from the Canadian Radiology Journal that showed a disease-free survival advantage to women who get breast MRI at the time of diagnosis. So I think we can cast aside the Monet trials and the earlier era trials that failed to show a significant difference because they were early in the experience and their numbers were probably not adequate to identify the significant difference in disease-free survival.
As we know from just having a debate session, we can get data to say whatever it is that we want. So I can stand here and Carla Fisher can stand here and quote multiple MR trials that don't show a benefit, as you and Susie may be able to quote multiple ones that do show a benefit. I think it's whatever we want it to say.
I think we do recognize that there are cancer subtypes that are underrepresented by mammography.
This is really interesting. I love seeing the technology of how 3D printing is just coming out with like all sorts of things, arts and crafts shows, as well as how it's coming into medicine. It's very applicable in customizing something to a particular patient. Do you think this is going to be easily adopted to lots of different places if they're interested?
I think the company will be able to meet the need of physicians when they order the MRI. I'm sort of not on that industry side, but clearly their goal is to create a localization device for surgeons across the country.
I think it's great research. Congratulations. Randomized control trials are very difficult to get off the ground and really get to the end. So congratulations on your work.
Thank you. Dr. Fisher, can I ask you what you were thinking there?
So for those who know me, my face shows everything. So you don't get to see that on the podcast, but there's lots of expression. So you were talking about disease-free survival with MRI. And I was also watching Dr. Bobel and seeing what she said with that. And I think she kind of covered it. But we've had a lot of discussions on MRI on the podcast. So I think I was doubtful of some of those outcomes. And that's why she was sort of going over that. But it's to be debated. But I think we do know that MRIs are not beneficial in many of our breast cancer patients, but there are select patients where it's certainly beneficial. And sometimes when there's an outcome maybe like this, or you're using something, it makes sense to do that. But we always want to be cautious about getting people to do that in all breast cancer patients.
And I think we came to sort of a consensus there, right? There clearly are cancers that we know ultrasound and mammogram underrepresent. And so that's where MRI-guided surgery is going to gain the greatest value.
I look at this and say it's a potential tool in our toolbox, and we need lots of tools because there's no two patients that are alike. So great work. Thank you so much.
Thank you. Thank you.
Please tell us a little bit about your poster.
So I'm Hannah Mathers. I'm down at Inova in Fairfax, Virginia. My poster is From Predict to Practice, a single institution retrospective review of outcomes in women with ductal carcinoma in situ tested with DCISionRT. So this all stemmed from our radiation oncologists seeing a large proportion of patients with low-risk DCISionRT scores having recurrences. So we wanted to look at our own data, and this is not industry-sponsored, as most of the Prelude studies have been through their own company or involvement. So even though we've ordered a lot of DCISionRT tests over the time, this was ourselves looking at our own data. So we did retrospective review of, it ended up being 500 patients from 2018 to 2023. And we looked at basically ipsilateral breast recurrences. And we wanted to break down into low-risk decision scores, so a score of 3 or under, which correlates with about a 10% risk of ipsilateral breast recurrence with no radiation therapy given, versus a high-risk score, greater than 3 on the score. And we found that no matter what, across the board, patients that received radiation therapy benefited in reduction of ipsilateral breast recurrences. But we did find that in our high-risk and low-risk groups, there wasn't as much a difference in ipsilateral breast recurrences with omission. Our high-risk group still had about a 6.5% risk of recurrence with omission, and the low-risk group was actually a little bit higher. It was 8%. So it's still under that cutoff that the company's putting out in terms of 10% risk. However, this was an average of 4 years of follow-up. They're using 10-year data. By 10 years, are we going to have much higher than 10%? And that's kind of our fear exiting this. So we definitely need more follow-up looking at these patients. Some of the other interesting things that we kind of found was some of these tests were ordered preoperatively. And a lot of those patients that had that residual risk category, meaning even with radiation therapy, their risk of recurrence was pretty high, about 15% or more. Some of those patients actually chose to get a mastectomy up front. So they didn't get included in this risk of recurrence data because we didn't include anybody that had mastectomy as their index case or even as a second surgery with margin issues, any of that. But we still found that there were a decent number of patients that used this test as a decision tool for mastectomy or not, even decision making. So now our radiation oncologists and our team are really using it as an adjunctive tool. It may not be the make or break decision on radiation, but it's something that provides some additional information to have that shared decision making with patients.
So does it surprise you, concern you, make you scratch your head that the low risk in 4 years, the risk of recurrence or the actual recurrence is 8% in 4 years in a low risk group without radiation?
Yeah. It makes me a little worried that after 4 years, we're already kind of getting up there number-wise. These are pretty small ends for each of these, I will say. So with radiation, it was 1 out of 29, 20 out of 250 without radiation. So it's still pretty small numbers, but realistically, you know, if we're missing some patients, if somebody was lost to follow-up that we didn't get to capture, or somebody still has imaging that's ongoing, there's definitely a risk that this number is going to continue to go up. It's still within the test's kind of reported guidelines. So it's reasonable to say, you know, maybe we won't hit that 10%. And that's a risk that you have to explain to your patients, that 8% is something that we might be taking on, and that could be a really real outcome for someone.
You're a fellow, correct? Okay, so in 5 months, you're out there in your own practice and this woman is sitting in front of you with DCIS. Are you getting this test?
You're listening to the Next Breast Thing podcast. We'll return in a moment after this brief message from our sponsors.
Breast cancer recurrence doesn't wait for symptoms. Signatera is a tumor-informed circulating tumor DNA test that detects molecular residual disease months before imaging. From neoadjuvant response to long-term surveillance, get unparalleled insights to inform next steps. Signatera is backed by Medicare coverage and more than 175 peer-reviewed studies. Learn more at natera.com/Signatera.
And now, back to the Next Breast Thing.
You're out there in your own practice and this woman is sitting in front of you with DCIS. Are you getting this test, this genomic assay?
I would definitely want to get a bigger picture of what's going on in this patient's care. Are there other factors I'm going to take into consideration beyond just a number of risk? And that may be her own, personal risk, her breast tissue. Is she going to adhere to endocrine therapy? What kind of surgical decision-making are we making together? I think I will still continue to order DCISionRT in practice, but it's going to be a little bit more specified to patients because there's going to be some patients that they're going to want everything no matter what that test says. And if there's any benefit that they're going to have from radiation, which in our study, no matter what, there was some benefit, they may just choose to do that no matter what. And that's not going to be a good decision maker for them. They've made up their mind. But I think in some of those patients that they need that information, it might be helpful.
I know you are a fellow, but you've obviously been kind of embedded in this for a little bit. We can send this test preoperatively or postoperatively, as you mentioned. And so do you have any thoughts about the right time to do it? Does it depend on the patient or the surgeons kind of do it at different times? Because I have heard of some people using it where they do it preoperatively, and then if they are very high risk, kind of regardless, they use it to make surgical decisions, like you said, mastectomy. So is there a right time to do the test?
I do think it's going to be patient dependent, and certainly the results that you get could change postoperatively. You might get somebody that preoperatively comes back as a low risk, but that's only a biopsy of their sample. They could end up having very different factors. They have to kind of input certain data for the clinical factors into making that score. So choosing that there's negative margins, choosing the size, and maybe the ultimate size ends up being much larger, or there's kind of some heterogeneity to it, and there's an area with a higher grade DCIS. So that score could definitely change, and I think that's something to take into consideration ordering it preoperatively. But I think in some patients that might be really struggling with that decision, or they have maybe some other issues with getting radiation, maybe it is a good decision tool for mastectomy or not. But choosing a mastectomy comes with its own slew of complications and changes to a woman's breast. So I think it's helpful, maybe an adjunctive test preoperatively, but I also wouldn't completely rely on it making that mastectomy decision.
Just one more question. Have you thought then about taking this patient cohort and separating out those who had a preoperative DCISionRT test and those who had a postoperative DCISionRT test and seeing if the results are different?
Results looking at recurrence specifically?
Yeah, like if there was any difference in those groups, that maybe the postoperative one is more accurate for those reasons alone.
Yes, we're definitely planning on looking at that mastectomy group because I have them specified out. If I remember correctly, I think one of them did have a recurrence out of, I believe it was around 27-ish patients. So we can definitely look at them a little bit more in depth. How did that affect kind of their outcomes? We have what kind of mastectomy they ended up getting even. So it might be helpful to kind of parse out, did that really end up making a difference? Because some of the people that end up choosing it are in this residual risk category of maybe they're not radiosensitive, but does that just mean that they have bad biology to their DCS? Are they going to still recur even if you do a mastectomy? So it's definitely something to take into consideration, looking at it more.
I love your thought pattern and super impressed with your work. Congratulations. Your future is bright.
I appreciate it.
We're seeing some impressive fellows here. Really bright group of people.
Thank you very much.
Please introduce yourself. Tell us who you are, where you're from, and what your poster's about.
My name's Taylor Fisher. I'm from Creighton University, Phoenix, with their general surgery program. My poster is talking about PEC blocks, specifically PEC 1 and PEC 2. We were looking at cost reduction for post-op pain at an underserved hospital. And we showed that patients who received the PEC 1 and PEC 2 block had a substantially less opioid requirements postoperatively, and therefore it was very cost effective for our patients.
Did you guys purely perform PEC blocks or paravertebral blocks performed as well at your hospital, or just PECs?
So we were doing PEC 1 and PEC 2. PEC 2 extends the coverage from the medial and lateral pectoral nerves to get some of the intercostal nerves as well. And anesthesia would perform the block prior to surgery.
Anesthesia, not the surgeons?
Yes. We were seeing a lot of our patients with extended periods of having long-term post-op pain, actually having to be admitted for procedures that we typically wouldn't need to admit for solely based off of difficulty with pain control.
Can you kind of tell us about the methods and what kind of patients did you select?
Criteria was specifically for patients undergoing mastectomies. Indications weren't evaluated necessarily, but we had 116 patients from our significantly underserved hospital. It's a county hospital. Roughly half of the patients received the PEC 1 and PEC 2 block, and the other half were just managed with traditional anesthesia and did not receive a block. Biggest thing that we noticed was the reduction in cost postoperatively from the opiates that they were requiring. And that included prescriptions that they would need to pick up, as well as costs in PACU and costs when they were inpatient as well.
How much cost was saved?
About a 90% lower cost. And I think the biggest cost difference that we saw was in PACU and inpatient. They were just not requiring much pain medication at all.
I think that this study is so critically important. When we look at the opioid crisis in our country, anything that we can do to decrease that, it really makes a difference. So I've been using PEC 1 and 2 blocks for about 8 to 9 years, and I have not written a prescription. I no longer even know how to write an opioid prescription. It literally makes that big of a difference.
Yes.
So a few questions. Did it add to OR time?
We didn't look at that specifically, but very minimal time added that we would notice between the two cases. That would be something to look at, though.
So it definitely does add, but you have to balance everything in life. I know some surgeons that will not use it because it adds another 10 minutes of OR time. The 10 minutes of OR time that we're utilizing, first of all, the patient, that means nothing to. And look at the advantage and the benefits to the patient. So congratulations, this is an awesome trial and really critically important.
Thank you.
And the fact that you're a resident, that's awesome.
Thank you.
You'll be up on the podium one day at this rate. Congratulations.
I appreciate it. Thanks. Thank you.
Carla Fisher. I'm on the poster session floor here at ASBrS 2026. And right now I'm joined by Kate Lloyd, and her poster is Long-Term Outcomes of 3,000 Nipple-Sparing Mastectomies. Tell us a little bit more about yourself, about the poster, what it's about, and the issue or problem you were trying to address with this work.
So my name's Kate Lloyd. I'm one of the breast surgery fellows at Mass General Brigham. We have a really robust database of nipple-sparing mastectomy that we reported patients undergoing nipple-sparing mastectomy between 2007 and 2019, and looking at long-term oncologic outcomes as well as implant complications. So we had about 1,800 patients, 3,000 nipple-sparing mastectomies, and a median follow-up of 94 months. Important highlights from our findings were about 67% of our patients were direct to implant. And in terms of our important outcomes were nipple margin positivity, which in the overall cohort was 3.7%, and nipple loss was 6.2%. All of our positive nipple margins were resected, and then about just over 2% were related to infectious or ischemic complications. In terms of oncologic outcomes, our nipple margin recurrence rate was under 1%. So we had 9 nipple recurrences in our entire cohort.
Did you happen to look at where the recurrences were? There was a publication or an abstract that might have been presented last year, and they looked at where recurrences happened in nipple-sparing mastectomy. We always worry about it coming back in the nipple, but a lot of times it's actually the upper outer quadrant, which is one of the difficult places to assess. So it is a low number, but in those 29 patients, I guess, did you look at where the patients did recur locally?
9 of them were in the nipple.
Where were the rest?
We don't have that granular data, but it would be good to look at that.
Did you all do any modification of where incisions may be in terms of where the breast cancer was to help that upper outer?
We actually do all of our incisions kind of inferior lateral, so basically between 6 o'clock and 9 o'clock. And that's pretty much where all of our surgeons make their incisions.
And then over this time period, did you see that the cup size of the breast or the amount of ptosis that people were starting to consider nipple-sparing mastectomy in not just the ideal AB cup?
Yeah, we actually employ pretty broad eligibility criteria for nipple sparings. So basically our main exclusion criteria are either radiographic or clinical involvement of the nipple, pathologic nipple like bloody nipple discharge or inflammatory breast cancer. But outside of that, we consider a pretty broad range of breast sizes and ptosis kind of in conjunction with the plastic surgeon.
There have been some people who've published on, I don't know if it's extreme nipple-sparing mastectomies, but they look at the size of the breast or the weight.
We have looked at that. Our largest nipple sparing, I think, in this database was like 700 or 800 grams. So, but that's obviously an outlier. Yeah.
So looking at this and looking at your nipple loss rate, it's a little higher than I would have expected. Have you looked at that based on the year that it was done, meaning the learning curve to nipple-sparing mastectomies? And early on, you had a higher percentage, and more recently, it was much lower.
I think that is true. I don't know the numbers off the top of my head, but recently we've had very few in terms of nipple loss.
So, Kate, one of the big things at the meeting is the robotic nipple-sparing mastectomy here. This is a great poster, I think 3,000 nipple-sparing mastectomies. This is the kind of data we want to look at. It gives us a lot of information and it's very helpful. So congrats on doing that. But you're also young and kind of early in your training, and a lot of people are talking about robotic-sparing mastectomy. So any thoughts on that?
Obviously, it's interesting technology and something that we should all be excited about and considering. Personally, I haven't had training in it yet. The big things are really waiting for some of that like longer term oncologic data that we don't have. And I think one of the nice things about this paper is we have basically 10 years of follow-up to show that we can do this safely. And I think that's still kind of yet to be seen in the robotic cohort of patients.
Great. Thank you for speaking with us.
Thank you.
Hi there, I am Susie Hagen, and I am one of the co-hosts on the Next Breast Thing podcast. And right now, we are at one of the top posters. So, Paige, introduce yourself and tell us a little bit about your poster.
Absolutely. Hi, my name is Paige Blinn. I'm a current breast surgery fellow at the University of Texas Southwestern. And our project is titled Patient Satisfaction with Robotic Nipple-Sparing Mastectomy, a prospective study of patient reporting outcomes using the breast Q. With the emergence of the robotic nipple-sparing mastectomy, we sought to look at patient satisfaction. And to do that, we administered the breast Q to 50 patients between 2022 and 2025. This questionnaire was administered preoperatively and at 6 months postoperatively. That way we had a baseline and were able to compare it. We analyze psychosocial well-being, sexual well-being, physical well-being, and satisfaction with the breast. The study included both patients undergoing risk reduction surgery at about 58% and patients with cancer at 42%. The median breast size was a B cup with a median BMI of 22.7. All the patients got immediate reconstruction, with the vast majority getting tissue expanders and a minority getting autologous reconstruction immediately. And what we found, psychosocial well-being was maintained at 6 months. And then when you compared our 6-month data to existing published data from another author who published on the conventional nipple-sparing technique, that our scores were higher across all domains.
That's amazing. This has been a hot topic here at the conference. What was something that was really surprising to you?
Seeing those domains still be lower, I then looked at the time that patients were getting their reconstruction. And for some of them, it was up to 5 months on average. So at the time of this questionnaire, they may still be recovering actively from their reconstruction. Since this was submitted in October, I've since looked at our 1-year data, and I have 45 patients, and we continue to see those other domains increase over time.
That's exciting. How long do you think you're going to carry out following these patients?
We have data within the data set going back to 2020 with this robust cohort continuing to expand. So I want to see the 1-year, 2-year, 3-year, 5-year, and continue that trend.
What do you think are next steps with this Singapore robotic trend?
I think seeing patient-reported outcomes, seeing sensation, if there's maintenance of sensation in comparison to open, I think is an exciting aspect while maintaining that oncologic safety.
How are you measuring sensation?
What we're doing is with the monofilament testing, we test them in the preoperative area for the baseline, testing them at 2 weeks, 6 months, 1 year, and so on. And then we're starting to analyze that data as well. So that should be something up and coming.
Thanks so much, Paige, for your time. And we are so excited to see this type of research. So congratulations.
Thank you so much. Appreciate it.
If you've missed out on joining us here in Seattle, I don't know why you would have, but if you did, or are simply wondering where ASBrS 2027 will take place, I want you to know we'll be back in Orlando, Florida at the Marriott Orlando World Center next April. It's a bit earlier, April 7th to 11th, 2027. Mark your calendars now and stay tuned. And as we say goodbye to Seattle and our listeners throughout the entire breast community, we're so excited you've joined us on this journey once again, and we'll see you next time on the next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.